slide deck. So Sandra, if you wouldn't mind advancing to the next slide. So the next slide is just my disclosure. So I do have a relationship with Indivior that makes Suboxone, doing some occasional advisory board work for them. And then of course, this program for the OPA and some work also for the Canadian Pharmacy Association. And this particular program, if you could go to the next slide, please, Cassandra, is supported by the Ministry of Health. So we thank them for that. I can see this is an older slide deck. Okay, go to the next slide. So we're going to look at opioid use disorder. What are the treatment options for it? We're going to look a bit at safe prescribing dispensing. What is a comprehensive opioid agonist therapy program? And then briefly touch on interprofessional collaboration at the end of this first 45 minutes or so that we have together. Go ahead, please. I'm going to skip through these because these are outdated, because my apologies, that's an old slide deck until we get to the one, this one. So if you could stop there, just go back one if you don't mind. So every year we are tracking the opioid related deaths in Canada, and this is the number of deaths from 2016. And then if we look, you can go to the next slide, Cassandra, please. If we look, I believe the next one's probably 2018 or something in this slide deck. Yeah, so 2019, these ones. And as you see there, it's about 3,700. And for the years after that, it kind of stabilizes around that rate. Went down a little bit, actually, interestingly. 2019 is actually a little bit of a dip. And then 2020, we don't have the data officially published yet, but 2020 data actually looks like it's going to be close to 5,000, which is definitely pandemic. Well, definitely, I can't say with certainty, but it really seems that it's related to the pandemic in some way. So I'm going to try and share my screen. I don't know if this is going to work from my other computer so I can have the more up-to-date slide deck. So my apologies, guys, for these tech problems. It's very frustrating. I'm sure to you guys and me as well. So just pull them up here. So all that to sort of set the stage that this is definitely an issue that sadly is not going away. It's a problem that we need to continue to address through treatment, but also prevention, of course. And opioid agonist therapy very much is the standard of care for opioid use disorder. So I've got the slide deck up here. Let me just see if Zoom will cooperate with me. All right. I would like to use this deck because I've really updated it with quite a few things. And the other one, I think, is actually a couple of years old. Okay, so hopefully you can see the slides. Cassandra, are they there? And they should flip into slideshow mode shortly, and I'll just get us to where we need to be. All right, so I like to start with a few cases just to kind of orient ourselves more sort of in the practical realm of a few patients. So this is Adam, and he's someone who has had quite a sort of long journey, let's say, with respect to opioids. Started with using some Percocet for musculoskeletal injury and progressed from there sort of through the late 90s, early 2000s to OxyContin at the time. And then let's say more recently, because of the changes that happened with, of course, the availability of OxyContin, we often see as change to heroin. And then, of course, fentanyl, as many of you know, at the moment is sort of our most problematic substance. Leanne, if you wouldn't mind making me a presenter, then we can do some of the polling. So this is Adam, so kind of keep him in the back of your mind and whether or not he has opioid use disorder. So he, in terms of just a few additional details, he has some functional effects from the opioid use with respect to his marriage falling apart, housing being a challenge, and also not being able to stay sort of steadily employed. So he's had quite a long journey with opioids. Thanks, Leanne. And then I'd like to turn our attention to Joyce. So Joyce is a bit of a different scenario. She's someone who has osteoarthritis, well sort of documented on her imaging, has some chronic pain for which she's taking codeine Contin, very stable, quite a low dose within sort of the guidelines for chronic non-cancer pain. And she happens to go away for a weekend, let's say. And let's say it's COVID, you know, travel's not easy, doesn't get back quite exactly when she expected to, and starts to experience flu-like symptoms, which much to her surprise some patients don't actually realize that this could be a thing. They often think, oh, I had a flu for a few days, but they had opioid withdrawal. So she has opioid withdrawal, but she doesn't have any of the sort of signs of misuse that Adam had. She doesn't really have any functional effects in terms of anything sort of negative psychosocially going on related to the opioid use. She comes back from her trip, she gets back on her medication, and sort of things truck along that way. And then lastly, we have a patient who's a little bit of a mixture of the two. So this patient, young woman, PSW or personal support worker, lots of physical work, lots of sort of musculoskeletal strains, at some point gets put on Percocet, let's say by her GP. And because of the kind of consistently physically demanding nature of her job, sort of has these strains that improve, and then perhaps another injury occurs, and she ends up being on Percocet for, let's say, 6 months, and the family physician becomes uncomfortable with having her on it for this period of time and decides to discontinue it. She has some ongoing pain and ends up sourcing opioids from a third party. Typically that would have looked probably like OxyContin, and now unfortunately it's probably going to look like hydromorphone, maybe even fentanyl powder. So let's keep her in the back of our mind as we sort of go through the next slides. And I'd like to stop here because I would like to know a little bit about you guys. So if you take a look on your screen, I'm going to launch a poll that really is just for me to get a sense of where you guys are in the province and what experience you might have with dispensing opioid agonist therapy. So hopefully you guys can see it. And I'll give you just a few seconds if you could answer those 3 questions. That would be appreciated. And we'll do a few more polls as we go through with some more clinical questions. This is just to make sure that it's working for all of you guys. Okay, so we have about half of you. I'll give you a little more time because some people have to sort of figure out where it is on their screen or perhaps get back to their computer. All right, so let's share. We have about 2/3. And apologies to those of you who are in some of the LINs that don't appear there. We're limited by the number of options that Zoom gives us, unfortunately. So we see that at least a quarter of people whose LIN is not present. And then we have a fair number of people from Mississauga and Toronto, but some nice representation really from across the province. So welcome everyone. And about 2/3 currently dispensing of those who responded, and a sort of weighted to about half with respect to fairly new. So, but we have a few with some extensive experience. So that will be sort of helpful in terms of sharing our experience if we're able to. It's a little more challenging on Zoom, but we'll do our best. All right, so get back to the slides. So just to review what is addiction. So it is as it a bit differently than it used to be. Say if we were having this talk 40 years ago, it is considered an illness, a primary chronic neurobiologic disease, not a moral failing or a disease sort of choice, as sometimes it used to be characterized, with a variety of risk factors. Genetics being certainly important, but psychosocial and other environmental factors very important as well. So when we're looking at making the diagnosis, which is critical if we're going to be prescribing opioid agonist therapy, our reference at the moment is DSM-5. in the process of just striking the committee to make DSM-6. So this now dates from 2013. And if we look here, this is the list of diagnostic criteria for opioid use disorder. For those of you who may be familiar with DSM-4, we used to have substance abuse, and then we used to have another category of substance dependence. And because of the confusion with physical dependence and the diagnosis of addiction, which was really what substance dependence was supposed to be, they really changed the language in DSM-5, and they combined them really to be one diagnosis on a spectrum of severity. So if we look at that severity scoring, they're really doing it by counting the number of criteria, with no particular ones necessarily being more important than the other. So mild is 2 or 3, moderate is 4 to 5, and severe would be more than 6. Just a caveat with respect to opioids: if the opioids are prescribed, they would tell us not to count criteria 10 or 11, because those would be expected physiologic phenomenon that we would see in someone who is taking opioids on a regular basis. So it's a little bit of a higher bar to get to have a diagnosis of opioid use disorder if someone is prescribing your opioids. So if we look just briefly at sort of the neural pathways that underpin addiction, it's very much related to dopamine. So this is the projections from the nucleus accumbens to what's called the ventral tegmental area, and sort of the deep brain. Some people will say like the primitive brain, the one that drives, all our needs in terms of survival and whatnot. Dopamine is there very much underpinning a lot of those functions, and then projecting into the prefrontal cortex, which is more the executive part of the brain, the part that's involved in decision making, and it really connects those two parts. We see that a lot in the behaviors that occur as part of addiction. So if we look at risk factors, as I alluded to earlier, there are a number. Genetics is one that is obviously not changeable, but important to know about, because the patient then can have sort of make informed choices around substance use, knowing that their risk is higher or lower than the average person's. And then we see other concurrent events or sort of environmental situations with respect to history of trauma, concurrent mental health issues, other concurrent substance use disorders, chronic pain, chronic opioid therapy, adverse childhood experiences. And all of these are definitely important in terms of understanding the patient and also trying to target different interventions to be complementary in terms of reducing the risk of the opioid use disorder. So in terms of the initial visit, we're really trying to collect quite a lot of the information around those risk factors. A lot of clinics, as you may know, are using an intake form, a self-report form that the patient would be filling out themselves with some of this information. And then the patient would usually be seeing a physician or a nurse practitioner, having a point of care urine drug screen, usually done there with the results available to discuss on the same day as the appointment, and then a discussion around treatment options. So critical in the first assessment is to figure out our diagnosis. We shouldn't be putting people who have no opioid use disorder or even really mild opioid use disorder on opioid agonist therapy. It really should be for patients who meet the moderate or more severe opioid use disorder. And we would, of course, have a discussion with them about their goals, whether it was to stop the opioids completely, to reduce them. It does sort of play into dosing and sort of understanding where the patient sort of may want to end up ultimately. And of course, we need to know about concurrent physical health, mental health medications, their sort of social situation, family history with respect to family of origin issues, but also their genetics, and then physical exam as indicated. So this, for some of you who do have a clinic perhaps located right near you, this may be familiar. Maybe your staff are involved in doing the urine testing. So this is one of many different test kits that are available. Previously, there used to be sort of a very standard panel that was available. Now we're able to tailor it to sort of what substances we may be seeing in our particular area. So back if we went sort of 15 years ago, we wouldn't have had a test strip with oxycodone on it, like this one, for example, or fentanyl, as this one does have. So we've changed the test strips really over time, depending on what substances are around, what substances we need to know about. So this one has, for example, ecstasy, morphine, oxycodone, benzos, fentanyl, and buprenorphine. So we're usually testing, or we should almost always be testing, unless perhaps we run out of test strips for the medication we're prescribing, to make sure that it's there, and looking for other things that we're usually hoping are not there, although usually benzos might be co-prescribed. And this result is something we would have immediately and be able to discuss with the patient, and that would help sort of guide us as to certainly dosing decisions with respect to methadone and things like benzos. But also when we start to give take-home doses, this becomes very important. Just to highlight for you, in terms of the reason you see the morphine there, sometimes it's called opiates, but it's really targeted to morphine and the naturally occurring opioids. So you see morphine, then you see oxycodone and fentanyl and buprenorphine separately, because the morphine or the opiate strip is not going to pick up the synthetic opioids, and their structures are quite unique. So we have the test strips are separate for each of those different opioids. So that's why you see more opioids on there than anything else. We're not able to do that, for example, for the benzodiazepines. If we wanted to know exactly which one it was, we need to send that to the lab for what we call chromatography, which is a different type of urine testing. So this is actually called immunoassay testing. And the lab would be able to do chromatography and give you, that's when you see results where they can see the sertraline, they can see the quetiapine and whatnot. So that's just a few things about the urine testing. With respect to treatment options, we are, the standard of care is to describe them all to the patient and tell them, of course, the risks and the benefits of each one. So we are required to tell them about detoxification, to tell them about abstinence, although those are not the first line recommendations with respect to patient outcomes. The first line recommendation for safety and reduction of relapse is opioid agonist therapy. So we tell them all this. If we have supervised injectable opioid agonist treatment available, which we don't really in Ontario, we would also tell them about that, and have them make an informed decision as to what they wanted to do. We also do need to tell them that if they go on opioid agonist therapy, they will become physically dependent on it, and that they will have withdrawal when they try to discontinue, and that should be tapered. So the most evidence for opioid agonist therapy is for methadone and buprenorphine. As you've likely seen in recent times, we're starting to use Cadian as well. We'll talk a little bit about safe supply, which is definitely still controversial. So that's usually with hydromorphone, but the most evidence still at the moment, and there's quite a lot of it over decades, is for methadone and for buprenorphine. And almost always when it's been studied, it's been part of a comprehensive program, including some counseling and case management, sometimes medical care as well in tandem. And our goal really, as you can imagine, is to give a long-acting opioid that's going to reduce withdrawal symptoms, reduce or maybe eliminate cravings, and help the patients to reach their goal of either stopping or reducing their illicit opioid use. So the idea behind the long-acting nature of these medications and why we select these is really to try and smooth out the peaks and troughs that happen when people abuse opioids, going from withdrawal into the therapeutic window, sometimes overshooting it into intoxication and overdose, sometimes purposely, sometimes often inadvertently. And this has an effect of what's called kindling in the brain. It makes the brain more susceptible to severe withdrawal symptoms, and it just makes it sort of, you can almost describe it as almost more jittery, more fragile, this constant oscillation between these different states of intoxication and withdrawal. And so what we want to do with our long-acting methadone or buprenorphine is we really want to smooth that out with a serum level that's just in the therapeutic window. We're not overshooting to get sedation into the intoxication, and we're trying to give them enough so that they're not experiencing withdrawal for 24 hours with the once daily dosing. So I'm going to talk about methadone, but I'll just stop to see if anyone has any questions sort of about addiction in general before we talk about methadone, and we'll talk about buprenorphine. Has anything come up yet?
Nothing in the chat box yet. If
Okay.
anyone has questions, just type them in and then we'll continue to pause. And
I usually stop again after methadone, so you'll have another chance there too. All right, so just to remind all of us, methadone, full opioid receptor agonist. It's an antagonist at Nmda. Onset is about 30 minutes and the peak is about 2 to 4 hours, which is sort of when we would ask patients when they're experiencing their sedation, if they're going to have any, it's usually then. A long half-life of 24 to 36 hours, and therefore steady state takes quite some time to reach. And so sometimes holding the dose, if you're close to getting 24-hour coverage, just holding the dose for another week can sometimes just get you there without having to increase. All right, so this is a polling question. Let me just get back into them. So why do we dilute to 100 mils of orange drink? I hope you can see that. Give you a couple more seconds. You guys are really doing great. 3/4 have already answered. Okay. So it's really all of these reasons. So the larger volume prevents someone from retaining in the mouth, spitting it out and diverting it or injecting it. The taste is bitter, so having a diluent definitely helps for that. So this is really what the guidelines recommend. So we tell them all this. If we have sure that it's there and looking for other things, you see results where they methadone and buprenorphine. As you've likely seen in recent times, we're starting to use Cadian as well. We'll talk a little bit about safe supply, which is and things like benzos. But also when we start to give take-home doses, this becomes very important. Just to highlight for you in terms of the reason you see the morphine there, sometimes it's called opiates, but it's really targeted to morphine and the naturally occurring opioids. So you see morphine, then you see oxycodone and fentanyl and buprenorphine separately because the morphine or the opiate strip is not going to pick up the synthetic opioids, and their structures are quite unique. So we have the test strips are separate for each of those different opioids. So that's why you see more opioids on there than anything else. We're not able to do that, for example, for the benzodiazepines. If we wanted to know exactly which one it was, we need to send that to the lab for what we call chromatography, which is a different type of urine testing. So this is actually called immunoassay testing. And the lab would be able to do chromatography and give you, that's when you see results where they can see the sertraline, they can see the quetiapine and whatnot. So that's just a few things about the urine testing. With respect to treatment options, we are, the standard of care is to describe them all to the patient and tell them, of course, the risks and the benefits of each one. So we are required to tell them about detoxification, to tell them about abstinence, although those are not the first line recommendations with respect to patient outcomes. The first line recommendation for safety and reduction of relapse is opioid agonist therapy. So we tell them all this. If we have supervised injectable opioid agonist treatment available, which we don't really in Ontario, we would also tell them about that and have them make an informed decision as to what they wanted to do. We also do need to tell them that if they go on opioid agonist therapy, they will become physically dependent on it and that they will have withdrawal when they try to discontinue, and that should be tapered. So the most evidence for opioid agonist therapy is for methadone and buprenorphine. As you've likely seen in recent times, we're starting to use Cadian as well. We'll talk a little bit about safe supply, which is definitely still controversial. So that's usually with hydromorphone, but the most evidence still at the moment, and there's quite a lot of it over decades, is for methadone and for buprenorphine. And almost always when it's been studied, it's been part of a comprehensive program, including some counseling and case management, sometimes medical care as well in tandem. And our goal really, as you can imagine, is to give a long-acting opioid that's going to reduce withdrawal symptoms, reduce or maybe eliminate cravings, and help the patients to reach their goal of either stopping or reducing their illicit opioid use. So the idea behind the long-acting nature of these medications and why we select these is really to try and smooth out the peaks and troughs that happen when people abuse opioids, going from withdrawal into the therapeutic window, sometimes overshooting it into intoxication and overdose, sometimes purposely, sometimes often inadvertently. And this has an effect of what's called kindling in the brain. It makes the brain more susceptible to severe withdrawal symptoms, and it just makes it sort of, you can almost describe it as almost more jittery, more fragile, this constant oscillation between these different states of intoxication and withdrawal. And so what we want to do with our long-acting methadone or buprenorphine is we really want to smooth that out with a serum level that's just in the therapeutic window. We're not overshooting to get sedation into the intoxication, and we're trying to give them enough so that they're not experiencing withdrawal for 24 hours with the once daily dosing. So I'm going to talk about methadone, but I'll just stop to see if anyone has any questions sort of about addiction in general before we talk about methadone, and then we'll talk about buprenorphine. Has anything come up yet?
Nothing in the chat box yet.
Okay.
If anyone has questions, just type them in and then we'll continue to pause. And
I usually stop again after methadone, so you'll have another chance there too. All right, so just to remind all of us, methadone, full opioid receptor agonist. It's an antagonist at Nmda. Onset is about 30 minutes and the peak is about 2 to 4 hours, which is sort of when we would ask patients when they're experiencing their sedation, if they're going to have any, it's usually then. A long half-life of 24 to 36 hours, and therefore steady state takes quite some time to reach. And so sometimes holding the dose, if you're close to getting 24-hour coverage, just holding the dose for another week can sometimes just get you there without having to increase. All right, so this is a polling question. Let me just get back into them. So why do we dilute to 100 mils of orange drink? I hope you can see that. Give you a couple more seconds. You guys are really doing great. 3/4 have already answered. Okay. So it's really all of these reasons. So the larger volume prevents someone from retaining in the mouth, spitting it out and diverting it or injecting it. The taste is bitter, so having a diluent definitely helps for that. So this is really what the guidelines recommend in terms of dilution. Occasionally, for clinical reasons, we might write on the prescription, please give in a smaller volume. It shouldn't be regular because it definitely does increase the risk of diversion. But for example, before surgery or for people who've had bariatric surgery, things like that, there may be some clinical reasons to not do the 100 mils. And with respect to which drink you're using, I think the OCP generally says we should be offering orange juice, apple juice for those who can't tolerate the orange, and then a diabetic diluent. We really don't want pharmacists to be spending a huge amount of time, preparing like a juice bar. We want attention to be paid on sort of verifying last doses, making sure the patient's safe to get the dose and the dose is correct, so that we can make it as safe as possible for the patient. And first, oh, there we go. Okay, so evidence for OAT, we have meta-analyses, we have Cochrane reviews, which is sort of the highest level, bringing together all the research studies that have been done over the years with respect to methadone and buprenorphine. So we are confident, we tell patients that this would reduce your use of other opioids, help with other medical sort of complications of injection drug use, for example, reduce overdose risk. And it also reduces a lot of the psychosocial cost of addiction. As you can imagine, if someone's not having to source opioids off the street to treat their withdrawal every day, they're not having necessarily to get as involved or involved at all in theft, in sex work, etc. And then we look at not just how many of the negative outcomes does it reduce, but how many of the positive outcomes does it improve, because that research is important as well. It's sort of inferred, but it's actually been studied. So we do see improved physical and mental health, social functioning, quality of life, and we definitely see improved pregnancy outcomes. And we'll talk about that a little bit in the second half of our evening together here. So this is just to say that the medications themselves are important in the fact that they're long acting. But another critical piece to the success of OAT is the structure that it brings to a patient's life in terms of coming to see you guys in the pharmacy every day in the beginning, going to the clinic, being awake during the day instead of at night, unless you happen to have a 24-hour pharmacy, which there are a few, but not a lot. It means that the patient is around and kind of more engaged in normal living, such that they can then maybe attend counseling, groups, treatment programs, their psychiatrist. It brings a lot of structure, which is another benefit to it aside from the medication itself. So if we look at dosing, this is all from the 2011 guidelines, which are currently the most up to date that we have at the moment. Certainly with methadone, not much has changed about methadone in terms of its potential for bioaccumulation. So these guidelines aren't likely to change that much, although there is some talk about tweaking them a little bit with respect to fentanyl, just because people's tolerances are so high and it's hard to engage them in treatment when those first doses really almost help not at all. So these guidelines stratify into 3 risk groups. So the highest risk being those who have had recent abstinence for whatever reason, the higher risk, and then the sort of lowest risk or no risk factors. And the starting dose is 10, 20, 30 for each of those groups, or anywhere sort of in between if you elect to go a little bit lower. So the higher risk patients, the highest obviously is the ones who've been abstinent, either because they've tried to be, or they've been in hospital or jail or traveled, or who knows, there's a variety of reasons usually. The next highest risk group is those who have been using benzos and alcohol, although I find that less common in combination with opioids. And a lot of the street fentanyl at the moment is contaminated with a benzodiazepine called atizolam that doesn't always show up on our urine drug tests. So that's sort of thrown in a little bit of another wrench, as fentanyl has thrown in quite a few wrenches to OAT over the last couple of years. And then some of the other higher risk scenarios are older patients with medical comorbidities, or people who have, as I mentioned, recently abstained, but they would be even higher risk. This is what we call the COWS scale, or the Clinical Opioid Withdrawal Scale. And I really put it here just to give you a list of opioid withdrawal symptoms and signs for your reference. We do use it from time to time when initiating Suboxone or buprenorphine to gauge the person's withdrawal in order to start them and not put them into precipitated withdrawal. But we generally don't use it much when we're doing methadone dosing. That just gives you a list of the withdrawal symptoms, which is essentially flu-like symptoms. So that is withdrawal. And when we're doing the dose titration, I'm typically asking patients, what time do you take your dose? How many hours do you feel that it lasts? What are the withdrawal symptoms that come back? And sort of how does that evolve until the sort of typical time that you would take your dose the next day? And what we want to see ideally is a progression of how many hours it lasts out of the 24. And we want to see ideally no sedation at that 3-4 hour mark when they're really at the peak of their dose. And so in terms of the guidelines, in terms of how frequently we're doing our dose increases, again, they were stratified into these 3 groups. The most typical you're likely going to see is the ones who are sort of average risk, which are getting 10 to 15 milligrams increases every 3 to 5 days until we get to what we call late stabilization, which is around 80 milligrams, and then we have to slow down a little bit. And then for the other groups, we're really going by smaller amounts. And for those who really have the lowest tolerance, who've been recently abstinent, the guidelines actually want us to only increase them every 5 days. So another question for you, just to make sure we're all still awake here. I know it's the end of a long day in the middle of the week. So why might a patient request a dose above 120, which is sort of traditionally what's been considered a high dose of methadone? Give you a few more seconds. So we've tried to make the questions not too hard. So again, it's all of the above. So ongoing opioid use would be a reason to go above 120. Sometimes we'll do an ECG just to check the QTC interval, especially if there's other QT prolonging medications or if they're using cocaine. But I find these days people using fentanyl have very high tolerances. So it's becoming more usual than it was for the last decade to have people above 120. Remember, sort of pre-oxycodone, there were quite a few patients above 120, and then not for a long time until the last couple of years. Then we have some patients who may be on medications that induce methadone metabolisms. There are not a lot of those patients, but there's a few. And then there's also a small subset of patients who are quote unquote rapid metabolizers. And so they will typically have a history, they take their dose and you increase it and you increase it and increase it. It always runs out of 12 hours and you can't seem to get past the 12-hour mark with once daily dosing. They usually need BID dosing. And the problem with that, or the challenge with that early in treatment, is do we give them carries or not? Because they're not yet stabilized. The guidelines would say we can't until we get them stabilized, yet they continue to really only have coverage in terms of their withdrawal for 12 hours. They're a small subset. If you have a physician whose whole practice, unless it's a pain practice, is full of everyone on BID dosing, that would be unusual. I find this is probably less than 5% of patients. We used to be able to do peak and trough methadone levels to determine that objectively, but I don't believe it's available anymore. I haven't done one in probably 10 years now. So that's all of the above for that one. Another one, just to keep our attention. So this one is about vomiting. So we have Julie, vomits 5 minutes after an observed dose of 55 in the pharmacy. What should we do? Okay, you guys are very fast tonight. Right. So this one is a little bit harder. So the answer is we replace half the dose under certain conditions. So she needs to vomit within 15 minutes of dosing. Someone on your team needs to observe that vomiting happening, and you do need to get another prescription from the prescriber in order to be able to replace that dose. So it does require another prescription. Depending on the circumstances, it's plausible that the prescriber may decide not to replace the dose. Maybe there's some high risk situation for which that decision is made. Usually not. I find most of the time we're able to replace half the dose. The reason we don't replace the full dose is because vomiting always leaves some amount retained in the stomach. And so the guidelines really were erring on the side of caution that we would still have some retained dose, so we shouldn't be giving like a whole full other dose there. All right. So just talk a little bit about medication interactions. So Julie started on escitalopram, and let's say she's on methadone, 20, and also concurrently, perhaps by another physician, started on clarithromycin. So what issues do we see here? So we see escitalopram, QTC issues potentially with that. And we also see the fact that it was started at 20, which is a little bit sort of higher than necessarily the average starting dose, which would of course increase the risk of QTC problems. So sometimes choosing a different antidepressant is better, or certainly starting at the 5 or 10 milligram dose may be more conservative. And then depending on how high the methadone dose is, checking the QTC. Ideally before you started, but sometimes not necessarily possible, so at least afterwards. And then our concern with respect to clarithromycin, this is one of the inhibitors of methadone metabolism. And I usually tell a funny sort of story about one of my very stable, lovely patients who came in for a regular visit. You know, usually it was just a chit chat. He was really stable dose of methadone, stable dose of a benzo that was reasonable, and came in and said, "Oh, doc, I was sick recently and I just got this amazing antibiotic. I love it. It's so good." Usually you don't hear that about any of the antibiotics, and certainly not about clarithromycin. And so I was definitely intrigued. And as I dug a little further, he was having some euphoria because it was inhibiting the metabolism. And after getting a little bit of a sense of what the indication was for the clarithromycin, it really seemed like it was most likely a viral bronchitis. And he wasn't severely ill, and we made the decision together, sort of much to his chagrin, although he completely understood why, that we were going to stop the clarithromycin and just continue on with the other doses. So that's one happy clarithromycin patient on methadone. All right, so if we miss a dose of methadone or buprenorphine and just one single dose, what is generally the guidance for you as a pharmacist? Okay, so yes, dispense the usual dose the next day and notify the prescribing physician. And at this point in the talk, I usually have someone who says, "Yeah, that's great, but sometimes I send things, or I call up a clinic, or I send a fax and I get a fax back being like, I don't care, I don't want to know," or something like that, which is unfortunate. And I apologize for those situations where that might happen. It is still your professional obligation to let us know. And some of us very much do appreciate knowing, because we will track the missed doses in a calendar. And sometimes it becomes relevant as we sort of look back and we're trying to make a tough decision about if we can safely increase or what we should restart at, to be able to look back over the past 2 weeks and sort of see what the pattern was in terms of what doses they got. Okay. So just to remind us all, because we all forget this about the first 2 weeks of early stabilization with respect to methadone, during this time period, we have a threshold for 2 consecutive missed days in terms of resetting things to 0, versus after the 2 weeks when we're kind of out of the woods, so to speak, where the patient can miss 3 days. And I have been trying to make it a practice to remind the patients of this, because I think sometimes maybe they're on the edge of coming in or not coming in on that 3rd day. And if they don't know this two day in a row rule for the first 2 weeks, then sometimes we're starting back to 0, much to their chagrin when they've missed 3 days. So that's early stabilization. It's just simply because it's a higher risk period in terms of overdose. So, and just to draw your attention to, if we miss 1 day though, we do have to wait until we get those 3 days in a row at the same dose in order to safely increase. In terms of missed doses after that, so I mentioned 1 to 2 days, keep going as long as the patient looks okay. And then 3 consecutive days is sort of this magic number. So sometimes you may get one of us calling and really wanting to know, like, did they miss 3 days or did they miss 4? Because that's the one situation where there's actually quite a difference in terms of what we're allowed to do. So we're allowed to rapidly retitrate if the 3 days have been missed, but if it's gone to 4 for methadone, then we really have to start back at 0. And so for the 3 consecutive days, we're allowed to go up by 10 milligrams daily for 3 days. And so that gets them back on the ladder, so to speak. And we drop by 50%, then go up from there. And that kind of gets them much further ahead than if we have to go back to 30 and start with our 10 to 15 every 3 days again. So now I'll just stop and see if there's any methadone questions before we start talking about buprenorphine.
So there's nothing in the chat.
Okay.
I do have one question for you. So we just reviewed the CPSO guidelines, which are from 2011. In community practice now, we're seeing a lot, a much more aggressive treatment approach for fentanyl using patients. Can you just comment? I'm seeing cases where physicians are increasing the dose when a patient has not had the same dose for 3 consecutive days, but because they're on fentanyl, they really want to keep them engaged in treatment. And other situations where they're wanting us to keep it at the same dose after 3 missed doses, like instead of reducing by 50%. So maybe you can just comment on sort of what's fentanyl.
Yeah, I think it's like next week I'm attending, and I've attended a few different kind of groups of physicians who've had discussions around this. And I think someone is eventually going to try to put something together more formally to kind of address this. But the key thing here, at least at the moment in the discussions as I've been party to up until this time, as I mentioned at the beginning of methadone, is like the bioaccumulation of methadone hasn't changed with fentanyl. It's still something that bioaccumulates, and that's really why the dosing is the way that it is. So what seems to be safer for sure is to continue our methadone dosing as for the 2011 guidelines, but to prescribe Cadian in tandem for that beginning period. And the reason being is that the morphine doesn't bioaccumulate like the methadone. And the Cadian formulation is the most sort of tamper resistant. It also is a 24-hour formulation, so it kind of mimics the 24 hours of methadone. So you may see scripts coming through for Cadian, and there are some guidelines, I can't remember, it's BC, that give us a little bit of a sense of how we might prescribe it, sort of starting with 60 to 120 and going up every 2 days by around the same amount. You may see us asking you to open the capsules and either put them on applesauce or put them in a cup and have the patient drink them with water. So as many of you guys probably know, but I actually only learned the ins and outs of this just recently. So the long-acting mechanism of the Cadian is within the beads, and it's related to the pH of the GI tract, as I understand it. So if we take them out of the capsule, they're still long-acting. So that's safer in the sense that we're not getting as much of an increased risk of respiratory depression by adding the Cadian and continuing the methadone as per the kind of safe way of doing it with respect to its bioaccumulation. So I hope that answers your question. So the people who, there are docs out there who are like, why can't we start at 40, 50, 60? Why can't I increase my patient after 2 days? Why can't I continue my patient on, 55 after 4 days missed? Some of those are probably okay, like perhaps the why can't I keep my patient on 55 after 4 days missed? But certainly some of those initiation things about why can't we start people at 40, 50, there's definitely not a consensus that that's okay, nor that we can kind of titrate them faster. Because this is before my time, but when we were initially starting with methadone in Ontario, so this would be pre 90s, there was a significant overdose rate for patients initiating on methadone, because they used to do things like they would give people naloxone or naltrexone and see how bad their withdrawal is, and then guess how much methadone they would give them based on that. It was very arbitrary. And again, it's about the bioaccumulation of methadone. It's not necessarily about the withdrawal with respect to the patient. So we'll have to keep an eye on it in terms of sort of formally what's out there. But that's the approach that seems to be a nice middle ground, is the adding of the Cadian for a period of time, usually hoping to transition all into methadone at a certain point.
Okay,
Does
perfect.
that make sense?
And we did have a couple other questions come in just now.
Mhm.
One I think you'll probably address in the Suboxone section, but the first question was, if a patient has asthma, is it better for the patient to be on methadone or Suboxone? So I don't know if you want to table that
So
Suboxone or.
it depends like how bad their asthma is, of course, right? So if they have asthma that's quite, we have many patients with asthma who are on methadone, they're totally fine. If they were like a really brittle asthmatic who is being admitted to hospital, every few weeks for an exacerbation, I may be a little bit more worried. So it really depends on the situation. But a mild, well-controlled asthma, either one would be fine.
And then one other question that came in, what should we do if a patient wants to take an Nmda receptor antagonist such as dextromethorphan with their methadone?
Oh, that's a good question. I am not a pharmacologist. I mean, generally, we wouldn't want to see them taking any like opioid-like substances, but we would have no idea if they were taking dextromethorphan and not telling us. As far as like a drug-drug interaction, to be honest, I'd have to look that up because I haven't had to encounter that particular scenario. I don't know if the person who asked it wants to add anything into their personal experience as to what happened. I don't have any personal experience with that particular scenario myself. Fascinatingly, because I'm surprised that's never come up.
And we just had one additional question. What if a patient on Suboxone or methadone wants to drink alcohol? Is there a time gap we should suggest?
I think a drink here or there is not problematic. It's when people are binge drinking that it really can affect, or chronic drinking. So binge drinking, is going to sort of have an immediate effect on the metabolism and change it sort of acutely. And then chronic drinking as well, you get an immediate induction of the liver enzymes from acute drinking, and then you actually get a reduction of them from chronic drinking. So chronic drinking almost in a sense is not as concerning because they're kind of in this steady state, and the methadone is also in the steady state. Of course, it's not good for them because they probably have an alcohol use disorder. It's more the acute binge drinking. So certainly if people come in intoxicated, and often you can't figure out what from, it could be alcohol, could be benzos, could be opioids. Those are the ones you would be most concerned about, but it could also, of course, be crystal meth or cocaine or all kinds of other things. But it's really important that if someone's intoxicated that you don't dose them. That they need to be reassessed by the prescriber, and we need to make some sort of determination as to whether it's safe or not to dose them. So I hope that helps a bit to answer that question. So I think we will just go on through the buprenorphine slides, and I'll stop at the end of those again, and we can see if there are some more questions at that point, if that's okay.
Perfect.
Okay. So buprenorphine, different than methadone, and this is the reason it's the first line recommended treatment for safety reasons, because it's a partial mu agonist. And it's also a kappa receptor antagonist at the opioid receptor, so the kappa subunit. And that's an interesting property of it because the kappa subunit actually has something to do with mood. So you may see patients, and I've had a few who struggle most significantly with mood as you taper them down, and not so much with the flu-like opioid withdrawal symptoms. And sometimes also conversely, of course, they will get, as you go up, they'll get a benefit on their mood, and it may well be coming from this kappa subunit. There's actually some case series of patients with severe treatment-resistant depression without any opioid problems, on whom buprenorphine was used, successfully improving their depression. Of course, it's controversial because then they become physically dependent on an opioid, but it gives us a clue into how buprenorphine can help for mood. So as you know, in Canada, the buprenorphine is marketed or available in a combo product with naloxone to deter intravenous use. We really haven't had much access to the mono product, although it is available through special access. We hardly ever use it anymore, and I'll speak a bit to that when we come to the pregnancy section. The currently available strengths that are covered by ODB are the 2 milligram, 0.5 milligram, 8 milligram, 2 milligram tablets. And then there are some other strengths that are available but not covered. So patients with private plans who don't want to have so many pills under their tongue may elect to have some of the other larger strength pills. And then just to remind all of us that there are other buprenorphine containing products available. There's the Transdermal Patch marketed as Butrans. It has an indication for chronic pain and not for addiction. So addiction would be off label. It's not covered. We don't use it very much for that reason. And we also don't use it that much because it's not very potent as compared to the tablets. So it comes in strengths of micrograms per hour. Occasionally, you might see it used in microdosing for a patient with a private drug plan, but that would really be one of the only scenarios where that might happen. So it's not that common. In terms of the maximum dose, as per the Canadian monograph, it's 24 milligrams. The American monograph is 32. The dose response curve between 24 and 32 is pretty flat. Occasionally, I find in the subpopulation of patients who have pain and addiction, those seem to be the folks who sometimes need 32, and they often need divided doses because the analgesic duration of action is not 24 hours. So they may get BID or TID dosing. So you may see some of them on 32. But if you see a practice that's not all sort of concurrent pain patients all on 32, that would be unusual. So buprenorphine, in addition to being a partial agonist, is also very high affinity for the mu-opioid receptor. And when it is there, it is near the receptor and binding. In the presence of full agonists, it will displace them. And this is where we come to the issue of precipitated withdrawal. So in this scenario on the left, you have a full agonist opioid like methadone or heroin releasing those little plus signs, which are dopamine. And when we put in the little green buprenorphines, we displace the full agonist and we get a reduction a relative reduction in the amount of dopamine there. The brain perceives that, of course, and there are resultant withdrawal symptoms. So this just gives you a sense or a bit of a visual depiction of full agonists being a really linear dose response curve. And then of course the ceiling with buprenorphine, and then for example, an antagonist with no inert opioid agonist effect. So if we think about someone like Julie, who was our PSW, who kind of started in Percocet and then kind of deteriorated into street use. So let's say, unfortunately, she ends up in jail and released for whatever reason, is not able to get opiate agonist therapy either in jail or upon release. And I find jails love to release people like on Friday nights and things like that. So often I'll get people on Monday because that's one of my clinic days where they've gone the whole weekend without anything. So she's using fentanyl, last used about 4 hours ago. She's got some withdrawal, pupils 4 millimeters. Her heart rate is a little fast at 80. And this time she says, okay, I want to try buprenorphine. One of my friends, said it was good, which I find is often one of the major driving factors in what people choose. Or my friend said it was really bad and I don't want it. So we give her starting dose of buprenorphine. And I'll talk a bit about microdosing, but I'll first just tell you what's in the sort of guidelines and the way we used to start buprenorphine before fentanyl powder came on the scene. So the guidelines say initial dose 2 to 4 milligrams, increase by 2 to 4 milligrams up to a max of 12 milligrams day one.
Okay.
Oh, okay. I hear someone. That's not me. So up to. Can you hear me? Okay. I hope you can still hear me. So it used to be 8 on day one. It's up to 12. And then day 2, again, 2 to 4 milligram increments up to 16, and then onwards, day 3 up to 24. So what happens to Julie? So we give her 8, and an hour later she vomits, has severe pain, heart rate goes up, and her pupils are more dilated. So what did we do? Unfortunately, we precipitated withdrawal. And if you're better with visual diagrams like I am, we're really trying to avoid precipitated withdrawal. What we want to do is have the dopamine be reduced, or through sort of previously would have been through naturally allowing the patient to go into withdrawal. The dopamine would slow, they'd be in withdrawal, we'd give them the buprenorphine, we sort of turn the faucet back on again, the dopamine would begin to flow. We want to avoid the opposite, which is having this nice flow of dopamine and then really turning off our faucet with the buprenorphine, or slowing it to a trickle and having them experience the precipitated withdrawal symptoms. So in the past, this was easy. I remember 5 years ago, I think I could count, I literally had like 2 people ever go into precipitated withdrawal with prescribing buprenorphine for like probably 5 or 10 years at that point. And same thing with the other docs in the clinic. We would make sure they were in moderate withdrawal. Sometimes we'd use the cow scale. Sometimes we'd kind of just wing it. And once they were, and we'd give them this guidance as to like when they would stop their short acting, 6 to 12 hours, when they would stop their long acting unless they chewed them. And it was easy peasy. And sometimes because of their pattern of use, maybe they only ever went into withdrawal at night. So we'd give them some buprenorphine to take home to do it at night. And we still do that from time to time. But then we had this experience about probably like 3 years ago now, I'd want to say, where we would have patients where they would be in moderate withdrawal, and then we'd give them the usual 2 milligrams, 4 milligrams of buprenorphine, and we would induce pretty significant precipitated withdrawal. And we're also just scratching our heads because this was so new. This was with the fentanyl users who were using the powdered fentanyl. And so the current hypothesis is that, and we know that the powder is a mix of fentanyl analogs created in labs. The sort of working hypothesis is there's a mixture of short and long acting fentanyls in this combination. It's very potent. And so we have the short acting ones dissociate from the receptor. The patient is in pretty good withdrawal. But when we give them those, I'll call them big doses of buprenorphine, we push out the rest of those long acting analogs, and their withdrawal worsens rather than getting better. So this is what brought us to the place of doing what's called microdosing, or sometimes called the Bernese method, because it's based on a case series of actually 4 patients from Bern, Switzerland. And so this was published, and this is really what underpins a lot of the protocols you might see. The one that's most commonly circulated is that developed by the team in London, Ontario with Dr. Ken Lee. And the idea here, it's off-label because we're using, I'm sure much to your chagrin, portions of 2 milligram buprenorphine tablets, which we recognize is very challenging in the pharmacy. We're trying to get small amounts of buprenorphine onto whatever receptors happen to have fentanyl dissociate with them from them in the beginning, and get them in there because they'll bind more tightly, and sort of accumulate those slowly, sort of like stealthily, until we can hit a threshold where there's enough of them that if we give those bigger doses, we're not going to be causing the precipitated withdrawal. So for patients who are using sort of short-acting, we'll call them short-acting opioids and fentanyl powder, usually we would do this up until we got to 4 milligrams. For the patients on methadone, it's usually done up till 12. And then rapidly sort of try and get rid of your full agonist. This method can be used to transition someone who's, say, misusing their prescribed morphine, and we want to transition them to buprenorphine. This is another way to do that. And there's no one single recipe. Some people will sort of taper if there's another prescribed opioid, they'll taper it in tandem as they do the microdosing. Some of them will keep it the same until they get to sort of critical level, and they'll just get rid of the full agonist or get rid of the methadone completely. But the underlying principle is we're trying to just sort of sneak the buprenorphine under the radar and build it up until we have a sort of critical mass such that we can start to do bigger dose increases after that. So I find the critical thing about this is patient education. Like most of the inductions that I've done that have gone wrong, the patient hasn't understood, or perhaps our instructions were not clear enough on the script that they were getting, a quarter of a 2. So they've been given a 2, and then they go into precipitated withdrawal and they think it's terrible and they never want to do it again. But the group in London has really had a lot of good success at doing it very supervised, making sure they're getting just the 0.5 and building from there. And that's their standard protocol in terms of initiating buprenorphine. So buprenorphine, in terms of missed doses, we can tolerate a bit of a longer period of time, so up to 5 days. And then I always refer back to this chart because it's a bit more complicated than methadone in terms of where we're going to start based on what their previous dose was and how many days that they missed. And we can titrate up quickly just like we could in the initiation phase. So in terms of sort of choosing between the two, the guidelines are all putting buprenorphine as first line because of that ceiling effect, because of the lower risk of respiratory depression, because of the shorter induction time. Now the cost is similar. That is not as much of a factor. And there's also a factor in terms of the ease of withdrawal and tapering off. So this is something that's not necessarily so cut and dry in practice, but theoretically buprenorphine is easier to taper off. And so some patients will choose it for that reason, or some patients will want to switch to it as they're kind of transitioning off of methadone. And that's not unreasonable, but I think we always have to think about the risks in the transitions. There's a risk of relapse when we transition from methadone to buprenorphine because there's a period of instability. There's a period where they may be uncomfortable for hopefully a week or two, not too long, and make sure that we want to take that risk for the somewhat unknown benefit of it being easier to taper off of. I find tapering is very patient specific and depends a lot on their ability to tolerate distress. And it depends a lot also on their patience in terms of doing slow tapers. Many patients want to kind of get on really quickly and stay on for a short period of time and get off really quickly. And I'm constantly having conversations with them saying, trust me, I've been doing this for many years. And the patients that I see that get off taper really slowly. And they also spend a period of time on a stable dose while they sort out the rest of their life. They don't kind of go quickly on and come quickly off. Almost all those people relapse, like literally virtually 100%. It's the ones who get on a good dose where they feel good for 24 hours, stay on it for, so we tell people 6 to 12 months at minimum, and then slowly taper off based on their physical withdrawal symptoms, ideally trying to have none at all. There's definitely studies that have looked at patients who tapered based on sort of, let's see how it goes, and go in stops and starts depending on when they have withdrawal symptoms or not, and patients who had to taper by a fixed time, whether that was externally imposed or not. Those patients relapsed considerably more than the ones who had this very sort of open-ended taper. So I find the biggest factor, honestly, is patient preference and the experience of their friends. That really seems to be what drives most patients' decisions in terms of which one they choose. So this is a question about methadone carry, so switching back to methadone for a second. 3 weeks of carries. What is your opinion? Okay, just for sake of time, I'm going to end share. So the answer is maybe. It really depends on the context. We are allowed to give up to 4, as long as the patient has a certain sort of level of stability. So it could be allowed, and especially sort of at this time in COVID, we have had a revision of the guidelines, not by the college, but by a sort of consensus group. And a lot more latitude being given, as you've probably seen in prescriptions that are coming through, in terms of how many carries we can give to try and keep people at home rather than being out and about. All right, so just to touch briefly on SROM, or slow release oral morphine, which is almost always Cadian, just because of the unique delivery mechanism. So I alluded to this a little bit earlier. So the idea here is that some patients fail methadone or buprenorphine, and this would be sort of the third line option for them. But also, as I mentioned, we've started to use it in tandem with methadone during initiation to try and manage the withdrawal symptoms without getting into the problems with the bioaccumulation of higher doses of methadone. There is very much a risk of diversion, as you can imagine. And it's still really not a consensus with respect to take-home doses. I think the BC guidelines say like you should never do it, which is kind of unusual for BC because they're usually very liberal. And my group that I practice within, we're trying to figure out sort of a consensus across the board as to how we're going to approach take-home doses for people who are on KDN. And these are the ones who would be staying on it for longer term. The ones who are starting it on at the beginning of methadone initiation, we're really hoping to have them only be on methadone by the time they're kind of stable and ready to take home doses. So diversion is definitely a risk. So please do look at the instructions if you're asked to open the capsules. I know it's tedious, but that's the reason, because otherwise it's so easy to stick it in your mouth and pretend you swallowed it and take it out. Or if you're handed it, put it in your pocket and walk away and divert it. So just to remind ourselves, it's a 24-hour formulation. The peak is actually a bit later than methadone, so it's 8.5 to 10 hours, but the elimination half-life is much, much shorter. And just to make sure everyone's aware that there are 2 other buprenorphine containing products on the market. So there's the subdermal implant marketed as Buprenorphine, and this is for patients who are stabilized on a lower dose on the dose range of buprenorphine of 8 or less. So this is a 6-month subdermal implant, usually put in the inner aspect of the upper arm, and you can switch sides and keep going that way for 6 months. And although the monograph says don't go beyond 24 months, because I assume that's how long they studied it for, some of our colleagues have successfully been able to maintain people for longer than that. And then sort of as a complement to Buprenorphine for patients who require higher doses of buprenorphine, 8 to 24, so they would need to be stabilized or sublingually for at least a week beforehand. And honestly, I find it's actually better to do even a bit longer, because as you can imagine, 7 days, you're not even reaching really steady state with your sublingual buprenorphine. So this is a monthly injection into usually the abdomen, and it's initially a higher dose of 300 followed by 100 monthly as a maintenance dose, with the provision that if that's not sufficient, you could do a maintenance dose of 300 if need be. So patients sometimes report some sedation in that first day because there's a bit of a bump in terms of the release of the buprenorphine initially, and then most of them are feeling pretty good for the rest of the days after that. So that's just a time for them to maybe not be driving, things like that. Okay, just a few things to say about collaboration, and then I'll give you guys a bit of a break. So in terms of pharmacist role, critical to the structure of the whole program of OAT, and very much as you guys know, you spend a lot more time over the month with the patient or your staff than the physician or nurse practitioner does in most instances. So initially in the beginning of treatment, you're seeing the patient daily. And so you would be in a much better position than us to pick up sort of changes in how they are. And it's critically important, as you know, for you to assess if they're safe to get their dose on any given day. But the feedback that you give to the physicians, the other members of the team, is sort of critical if you notice something, and particularly if you're seriously concerned about their safety. We definitely should be informed of that and be able to help sort of create a plan together with you as to what the next best step might be. In addition to doing all the things around the prescribing, a lot of pharmacies, as you know, are providing naloxone. Some are even providing safe use supplies like needles and safe crack kits and things like that. And lastly, just to touch on sort of the importance of setting the tone of inclusivity and trying to reduce the stigma that our patients already feel from so many interactions with the healthcare system, in terms of your role as the pharmacist, sort of setting the tone for how the entire store or team may treat patients who come in to get OAT. We know that our OAT patients really do not engage in healthcare, especially outside of sort of the safer places where they feel that there's less stigma or judgment. So it's sort of critical in terms of having them feel comfortable coming to you. And we also, I think a lot of our colleagues have reported, if you can kind of build some sort of relationship with your patients when difficult things happen where you may have to withhold a dose, or you may have to have them wait longer because you have to contact us, and things that, you know, may cause them to become frustrated, at least you're sort of building from a base of having some relationship with that patient usually helps to have those difficult interactions go a little bit more smoothly. So I will stop there and see if there's any last questions. And I do want to give everyone a little bit of a break before we go into the second slide deck.
So I think your one slide already addressed this, but the one question from Krista, are there any resources that you can recommend regarding using methadone and Cadian together? We're seeing this at our pharmacy and would like to have some documentation available for all staff to read.
I will have to look at what the document I have on my desktop is. I just have so many different of these random sort of documents that different groups have put together, and I'll send it through to Alan. I believe, not that this answers this specific question, but I believe I've also sent him the microdosing guidelines, I'll call them, the sort of microdosing document from the group in London. So that's another useful reference. I can't recall if the Cadian document has about in tandem prescribing, but it definitely has some guidance in terms of how to prescribe Cadian, which is sort of the same way that we prescribe it in tandem. So I will find that and I'll send it to Alan.
And then another question that came in, I have a patient who came from the States. They were taking buprenorphine, pure buprenorphine in the US, but when they switched to Suboxone here, they started getting headaches. Patient was on 8 milligrams. The solution was to change the prescription to 2 milligrams 4 times a day. Is headache a common side effect?
I mean, headache is a common side effect. I don't know that it was due to the fact that it was the combo product, because the naloxone really is not absorbed sublingually at all. It's kind of as if it's not there. And we'll talk about that as it pertains to pregnancy in the next half. So hard to say, like, you know, there are a few different generics available. So sometimes just switching around or using brand name, or trying to just see if we can use the same dose, but use a slightly different formulation. Maybe it's one of the excipients that they're reacting to for whatever reason. But headache is a reported side effect from buprenorphine.
And do you see patients who are below the ceiling dose of Suboxone who also split their dose BID? I have heard from a few patients that they need to take it twice a day to avoid withdrawal, despite the prescription being written once daily.
It definitely happens. It definitely happens a bit more, I would say, with methadone patients. It happens more frequently also for patients that have concurrent pain. Like that would be something that would be quite frequent for if a patient had opioid addiction and chronic pain. They will often need to split their dose BID or TID to have the pain controlled. So it's always about kind of teasing out those questions, like, are they truly having withdrawal at the 12-hour mark, or are they having pain? And sort of regardless, it still makes sense as long as they're stable enough to take that second dose as a carry, or they have carries ready and they're just going to split it on their own. There's nothing really wrong with that at all, per se. The issue about BID dosing is really for patients who are unstable, who really shouldn't have carries. And then it's kind of like, well, what do we do? They need BID dosing, but they're not really safe to have it. And that's always the challenge. Nobody wants to come to the pharmacy twice a day. That would be rare. And so what do we do with those people?
And just a couple questions about Cadian. One participant has asked, does the Cadian capsule have to be opened and in applesauce? Or
so
yeah,
according to the BC guidelines, it has to be open. It doesn't have to be in applesauce, because we recognize like not all pharmacies have applesauce. So in that event, the suggestion is to open it, put the beads into a medicine cup, and have the patient drink some water. It could even be in the cup to make sure they get all the beads, and then make sure that the beads went into them, followed by the water, and that there's the risk of diversion is pretty low if we do it that way. Mm-hmm. We're not supposed to be giving them capsules, even witnessed swallowing. We're supposed to be opening the capsules.
And have you ever heard of K being given Q4 to 6H due to GI tract absorption difficulties?
That sounds weird to me. My understanding is but I'm certainly no expert in Cadian, so I would have to ask more questions about that one myself. My understanding is that due to the different pH in the stomach and the small bowel, that is sort of how the long-acting release happens. Of course, that's going to change for patients who've had stomach surgeries or bowel surgeries. I'm not sure if the solution is to split it up into Q4, Q6 dosing. I would probably have to ask the GI person who is managing whatever the GI issue is, sort of what their thoughts are based on the mechanism. That's a bit of a question beyond my expertise.